I'm a member of something called the National Academy of Medicine. In 2010, we did an evidence review. We applied Deming's models to healthcare delivery around the idea of waste. The key takeaway in that report, we concluded that a minimum of 35% and probably 50%, over 50% of all money spent on healthcare delivery today in the United States is non-value adding from a patient's perspective, is technically waste. I will admit that one person's waste is another person's income. Politically difficult challenge. Now, I'm a little bit of an outlier. When I model it, I get close to 70% waste. Unnecessary care, inefficient care, supply chain, a whole series of issues back behind it. Now, an interesting thing about waste. First, it's a huge opportunity. This year, the United States will spend about $3.4 trillion on healthcare delivery. So I'm talking about a potential market opportunity, a value opportunity on the order of $1.7 trillion. A huge financial upside. The other interesting thing is you start to look at waste versus growth. If I add a new service, I expand my imaging, for example, or build that new heart hospital, if I do well, about 5 to 9% of my revenues will actually find its way to my operating margins for a successful, well-managed service. If I eliminate waste, the margin contribution ranges from about 50 to 100%. So it turns out that waste elimination has about an order of magnitude higher leverage, financial leverage for the same effort. In terms of the success of a care delivery business. The argument is that we should be focused on waste elimination very, very heavily. The third point, published this last summer in, of all places, Harvard Business Review, a first for me. It turns out that you can structure the nature of waste into 3 tiers. I won't go into the details. Suffice it to say that those 3 tiers interact with payment mechanisms. When you're talking about a value equation, somebody has to make the investment to drive the change, and sometimes the investment's fairly large. The question is who gets the savings? The red triangles represent the payers, the government, the insurers, getting all of the savings, even though they don't make the investment. The care delivery groups have to make the investment. The green triangles show where it actually aligns, where those who make the investment get the savings across those 3 tiers. I think that was a very important recognition that payment mechanisms, it shows what's called cost plus. It only exists in a few places anymore, but included it for completeness. Fee for service, the traditional pay for volume methods that most of healthcare currently employs, per case payments like DRGs versus what's called provider capitation, provider at financial risk. You can see why my system, at least, is driving as fast as we can into full financial risk. We're currently at about 40%. The tipping point's down around 25%, but it turns out it's a much stronger financial model. And what I see coming is a huge transformation in healthcare as we drive more and more on a value proposition into new models of payment. Interestingly, single payer doesn't make any difference with this. Oh, the waste levels across Europe, Canada, Australia, the rest of the free world, similar levels of waste in all of those countries. The idea that it's public health policy doesn't play through. It turns out it's more about how the profession functions than the health policy. Just to make it real, this shows our last 4 years at Intermountain. I'm still waiting for the 2016 data. We set a goal to reduce our burden on the community. Short version, through those 4 years, we took about 13% out of Intermountain's cost of operations, about $690 million out of our cost of operations. We're a small company, though.
The most common question we're often asked is something along the line of, we've heard about Lean Sigma and know that it's applicable in industries like electronics and automobiles, but does it really work in healthcare? And the easy answer is, yes it is, and it's been working for us for several years now. We've had projects that do everything from reduce billing errors and billing cycle times to taking blood waste reduction down. We've saved hundreds of thousands of dollars on some projects, and others we've cut patient wait times in half. So the answer is absolutely yes. The follow-on question is usually something like, well, you're Hopkins, would it really work for other institutions? Because Hopkins is a big institution, has a lot of staff, endowments. But really, when you look at the projects that we've done, they really don't cost a lot of money. The biggest investment is the investment of people's time. It's getting down to the root level of the processes. You've got staff projects in labor and delivery or in the chemo pharmacy that we've done, where they've had great improvements with no capital expense at all. So the bottom line is that these tools work in healthcare. We are a great example. You can be a good example too, because it doesn't matter the size of your organization. These tools work and they yield great results.
Quality is important to me because I think that we all have two jobs: the care that we give and improving the systems in which we work. That's our professional responsibility. I started my career as a nurse, but even before that, I'm the oldest of 9 children, a big Irish family, and when the first nephew was born to my sister, you can imagine what this Irish family was like. We were all responsible together to take care of this wonderful little kid, Robbie. When Robbie was 2 months old, he went to his doctor, had his first checkup, and the doctor told my sister that he was great. He was developing normally, everything was fine. At the end of the visit, he gave him his DPT vaccination. When my sister got Robbie home, he started to become ill. She brought him right back to the office, and he ended up in the intensive care unit for about a week. He eventually got better, and the whole family came together to make sure that he was safe. When he went in for his 4-month checkup, the doctor said he was perfect, he was developing normally, and at the end of the visit, he said to my sister, "I'm going to give him his DPT vaccination." And my sister said, "Don't you remember what happened the last time?" He paused for a moment, and then my sister recounted what happened, and he said that had nothing to do with it. But then he paused and he said, "I'll give him half a dose." And he gave him half a dose, and Robbie died within 24 hours.
When you think about the story of your nephew, do you think that's an anomaly? Do you think that it's a sort of a rare thing? Do you feel like it was indicative of a much broader problem, or do you think this really was kind of an unusual case that got you thinking on this?
Well, it is not rare. Perhaps that particular circumstance, but the fact that patients are harmed by their care instead of helped by their carers is unfortunately all too common. So my sister asked me 3 questions that changed my whole outlook on my career as a nurse. The first thing she said is, "Why do you keep records separate? Why are the hospital records separate from the doctor's office records?" The second question she said is, "Why did he not know that that wasn't the right thing to do?" And then the third thing she said, "Why didn't he listen to me?" And those 3 questions really changed my outlook on what we need to improve in quality in healthcare and how we need to go about it. In some cases, it's a failure of information. An example, one of our staff here was taking his father home from one of the hospitals here in Boston after having an aneurysm in his brain repaired. And as the nurse was preparing to discharge his father, my staff member went and said to the nurse, "Do you know what his situation is when he gets home?" The staff member's mother is totally incapacitated, and his father was her carer. And the nurse had no idea. Now, you might not think that that's harm, but I do think it is. To send a patient home to a circumstance without complete understanding is harm. Yep. Patients developing pressure ulcers in a hospital is harm. Ventilator pneumonias are eliminatable now. Yep. And so I think these all represent professional challenges to us because we do know how to eliminate these.
So what's the challenge? I mean, why does this happen? Why do these harms occur? What's underlying it?
Well, I'd say 2 things. One is, in our professional education, we're taught how to care, how to fix things. We're not taught how to improve. Several years ago here at IHI, we were trying to get improvement built into the curriculum for medical schools and nursing schools, healthcare administration programs. We found it very hard to get people to integrate that curriculum and to teach cross-professionally.
Yep.
The second problem is we work in broken systems. And in our educational processes, we're taught to be heroes. We're taught to fix it for the individual, not to fix the process and the system.
Yeah.
So two things, I think. We need to build improvement capability, the science of improvement, into every curriculum, into every professional program. And then we have to be able to see.
Yeah.
We have to learn that when we're in a situation, not to fix, but to see.
Yeah.
And once we see the system, we can make it better for all.
Those are two great points. And certainly as a clinician, the notion of improvement as a part of my job is not something I spend a lot of time thinking about. And I suspect most clinicians, not very much time. And then the second notion that you bring up, right, very much we think about fixing it for individual patients because that's our job, but never sort of taking the step back and saying, how do we fix this, not just for my patient in front of me, but the patient I might have a month from now, or your patient that I will never see.